This is the Hypotension and Arrhythmias lecture for North America. If you're anywhere else in the world, you want the previous module. They're actually very similar, but just a little bit honed for the USA audience. Also of note, if you want to actually see how I give this lecture, you need the provider course. I'm going to be trying to give you hints and tips of how we as trainers like to give this lecture. So we start off by saying how important low blood pressure is, and the quicker we treat it, the better it is, and the more ill they are, the quicker we're going to have to be. But the most important slide is coming up next. This is the most important slide. You're doing this lecture in preparation of us and go and sit down with them and do scenarios where we practice this, and we want them all speaking a common language. Now you're trainers, you know exactly how to treat low blood pressure, but we want to get this 5-point plan really going nicely because we think it really helps people. So we want you to teach them to do, yes, an ABC assessment, hone down the fact that, a tension pneumothorax is a great way of having a low blood pressure, and you'd look pretty silly if you miss it. So ABC assessment, but don't just dive in there. Don't just say give fluids, start norepinephrine. We want them to stand back and loudly and clearly give a diagnosis so everybody around knows what they're talking about. So after they've done a diagnosis, everything's going to shake out after this. All the slides are set up to have 5-point plans, and we want them in the scenarios to give it in this orderly fashion. So make a diagnosis, then an action plan, and then after that, once you've done an action to try and improve the blood pressure, you're going to investigate to see if your diagnosis was correct or not. Then obviously once you're starting to get the investigations back, that your treatment's kicking in, you're going to need to reassess to see if you've got it right or wrong. And that's the 5-point plan, absolutely vital in the CSU ALS course. So spend some time illustrating the importance, talk about how it's a common language and how really this gets away from that wondering whether the physician really knows what he's talking about, because you're all worrying there, tamponading. So we talk a little bit about the assessment and just teach them about, what you're going to look for in the airway if they're intubated or extubated. We'll talk about breathing, listening both sides, looking at the drains, and then moving on to circulation, what exactly you're going to look at. It's my belief that in America most people get a swan line or a PA catheter. In the rest of the world, people don't routinely have PA catheters. That comes a lot in investigations in other talks, but I kind of assume that in America most people have a PA catheter. Just make the point to look at the urine output and the chest tubes as well, don't forget that. And now make your diagnosis. Stand back, take a deep breath and make a diagnosis. But at this point I like to tell them, don't worry, it's super easy. There's only 3 causes of a low blood pressure: hypovolemia, vasodilation, or a low output state. We all know that there's a few more causes of a low output state. They can be split up, but actually we're going to treat them just the same for the first 5 minutes, and the slides will show us how that actually works really nicely. And there's only 3 causes of a low blood pressure is very reassuring for people who aren't used to actually doing the treatment or aren't sure about patients post-cardiac surgery. So it's a really good message to give. We're going to do some actions, and actually in following slides it'll tell you what the actions are for each of the key 3 causes of a low blood pressure. So next we move on to investigations. Now I've tried to set this up to be fairly easy, so there are 2 lines of tests. So the very first ones you want to reach for is going to be a blood gas. That's going to be great for, is the hemoglobin going down? What's the U's and E's if you've been giving a lot of fluid? Are they acidotic? Great fast test. With that you're going to want more definitive things like the CBC and Chem7, so you can actually see the definitive hemoglobin, what the platelets are. You want coagulation for most causes of a low blood pressure, just to check that it's not a coagulopathy that might be causing the bleeding. And I always like to reach for a chest x-ray really early. It's great for hypovolemia. If they're bleeding, there might be a big chest full of blood. It's good for vasodilation because there might be sepsis, and low output state there'll be a big globular heart. So I've tried to set it up as 2 lines of tests. That's the first line that they'll all reach for, the same for all the causes of a low blood pressure, and then a second line of more detailed tests, the sort of second line that you reach for. Now I call these the key 3 tests, and it's a swan or PA catheter of some type, an echocardiogram and an EKG. Obviously, with that comes get some help any time. But these key three tests are absolutely vital for telling vasodilation from a low output state. Vasodilation is a guess until you've got a swan or an echo. Now, I do know that in America, quite a lot of people have a PA catheter. So if you wanted to have kind of the key three steps, I suppose you could instead teach echo, EKG, and get senior help. But echo, EKG, and PA catheter is going to be able to tell you every single cause of a low output state and vasodilation. So I hope that's fairly simple. 2 lines of tests, so they only have to remember that and decide which they want. Well, if you've done investigations, you've got to reassess. And it's at this point I try and highlight, don't just walk off and wait to be called again. Make a plan, tell people when you're going to come back to see if things are working. So we then move on to the 3 causes of hypotension. The smart Alex might say, what about fast heart rate and slow heart rate? And so I come back at that saying, when did you last get called for a blood pressure of 70/50 and noticed just as you were coming to the end of your ABC assessment that the heart rate was 250? You tend to notice fast and slow heart rates first. So that's why we've separated them. So now the slides on hypovolemia, vasodilation and low output state are all set up as using the 5-point plan, and that's the way we want you to teach it, and then in the scenarios that's the way we'd like you to reinforce it. So this is what they'll hopefully find in the assessment. Stand back, say, I think this is bleeding. Then instantly that's telling you this is the action you've got to do. Some colloid or some red blood cells, or later on maybe you're going back to theatre. There's your 2 lines of tests. Certainly in hypovolemia, probably just going to go for your first line of tests because bleeding, there's blood in the pot. So that second line of a swan, an EKG and an echo is probably not going to be useful. And then reassess. A little bit more detail on what you're going to do here. And then moving on to the next one, vasodilation. We've got your ABC assessment, what you're going to find. Stand back, say vasodilation, and then this is what you're going to go and reach for. The norepinephrine, 4 and 50 start at 5. That common language, we've tried to reduce as much as possible the different drugs we recommend. So norepinephrine for vasodilation, epinephrine for low output state, both at 4 and 50 start at 5. And then we've got our 2 lines of test. Initially, reach for that first line, ABGs, chest x-ray, CBZ CAGs, Chem 7. But once you've reassessed and you're still not fixing the problem, then you want your key 3 tests, an EKG because it might be ischemia, it might actually be a low output state, transesophageal echo just to again make sure it's not a low output state. A PA catheter gives you the answer, SVRI is low, cardiac index is high, and senior help to help you out if you like. And then a little bit more detail on that. And then this is the big scary one everyone doesn't like, low output state. We try to say it doesn't matter what you say for low output state, whether you say I think they're tamponading or I think their heart's not working, whatever, as long as it's low output state. There's our key drug that we use. And then 2 levels of tests. The first level, blood gas, to see if they've dropped their HB causing tamponade, or chest x-ray, globular heart, CBC, the HB might be low, they might be coagulopathic with low platelets, coagulation and Chem 7, you might have given lots of fluids, so their potassium might be low. But then the second line of tests, an EKG for ischemia, an echo for tamponade, and a swan to look at a low cardiac index, they're the key 3 tests that keep you safe. So I think that's a nice simple way to teach the investigations. And then this slide just then reins back a bit on that. We can all treat it the same, because you can initially, but then once you've established the diagnosis, you've done your key 3 tests, it's going to be one of these 4 things. So if it's a tamponade, you could open them straight away in your ICU. But if it's ischemia, you absolutely don't want to open them in your ICU. You want to go around to a cath lab or go to theatres. Again, if you had a valve failure from a mitral repair failing, you totally don't want to open them in the ICU. They've got to go to theatre. And then if you've excluded all those other causes of a low output state, you've just got a really bad heart, then you can avoid reopening at all. But this does highlight the fact that comes a lot further down the line, and in those first few minutes it really does work quite well, just calling it all a low output state. That's probably the most important part of this slide. We then go into some detail of what you do with tamponade, with ischemia, the options, valve failure if a repair doesn't work, etc., and then just normal cardiac failure. And I'm sure you all know that very well. And then this is just a sort of summary of how you're going to treat a low cardiac output. We do make the point that epinephrine is not great for the heart. It causes arrhythmias. You don't really want to just be throwing it around, and actually a balloon pump is a really nice way to offload the heart, to give the heart less work. And that probably should be highlighted here. So that's the 3 causes of a low blood pressure. Easy peasy lemon squeezy, as they say in the UK. We then separate off a fast heart rate and a slow heart rate, because I think that's what happens in practice. So we teach it here. So we teach tachycardia in the 5-point plan. We've tried to keep this protocol, although investigations are a little bit further down the importance level. We talk a little bit about when is it an arrhythmia versus sinus tachycardia, but we try and go really low on which exact type of arrhythmia is it. People sometimes aren't that confident with it, but we're going to try and teach them that it doesn't really matter. Whatever the tachyarrhythmia is, we're going to treat it the same. If they've got a good blood pressure, they're getting amiodarone. If they've got a bad blood pressure, they're going to get shocked. So that's how we're going to teach it, whatever that arrhythmia, and that works pretty well, really. This is the little caveat of sinus tachycardia. Just look out for those P waves, because obviously you're not going to treat that with amiodarone. That's tachycardia. Now this is bradycardia, even simpler. We try and teach it in the 5-point plan technique. So we want them to assess it. Yep, the heart rate's 30. I diagnose bradycardia. We're not bothered about them saying a heart blop, is the Wenke back, etc., etc. We just want them to diagnose a bradycardia, because we're going to treat it just the same. We're going to pace if there's pacing wires, and we're going to use drugs to get the heart rate up if there's not. Again, investigation's slightly less important, although high potassium can be a cause of bradycardia, etc. So without pacing wires, here's our list of drugs, and atropine, then isoprel if you've got it. You can use epinephrine, but not really that commonly done, because you're probably going to want to use some kind of external pacing. That's probably a good point to actually talk about how you set up external pacing here as well, if you've got time. And then obviously I've got pacer box. Then that's simple. Press the emergency button, but do remember to then set it properly as soon as you've got the blood pressure back. So summarize again with the 5-point plan. Tell them that you'll be using this very shortly when they come to do their scenarios. And best of luck teaching it in that framework. I hope you find that logical and useful. And I'd be very grateful for any feedback you have when you teach it. Thanks a lot for listening.